In this episode of EHA Unplugged, we will revisit a spotlight talk from EHA 2024. Dr. Michelle Lavin from St. James's Hospital in Dublin discusses optimizing global care for women with von Willebrand disease.
Good morning, everybody, and I'm honoured to be given the opportunity to speak today, but also for EHA to actually prioritise this area of women with bleeding disorders, which has long been neglected, I think, by the community, not only in hemostasis and thrombosis, but of all of haematology. My name is Dr. Michelle Lavin. I'm a consultant haematologist treating adults with bleeding disorders in the National Coagulation Centre in St. James's in Dublin. And I'm also a researcher in the Irish Centre for Vascular Biology in the RCSI. And as you can hear, very passionate about the care for women and girls with bleeding disorders. I'm going to start with a question. And that question is, why is it okay to trivialise bleeding in women? Because this happens on a daily basis. And it's, overt and pernicious within our medical societies. And this case is a lady who was in with me recently, and it really exemplifies what we see on a very regular basis in my clinic. So I was referred an 18-year-old woman who had, the point of such heavy periods that finally somebody thought, could this be a bleeding disorder? But she had suffered from long-term iron deficiency throughout her teenage years. She had had nosebleeds as a child and was advised that she would grow out of them despite needing cauterization in childhood. And she had easy bruising, but that was, normal for her. And I think we forget to ask, how has this impacted you the most? Or where has your bleeding caused you the most trouble? And for her, it was that she loved to dance. And she used to do ballet and hip hop, but the classes were an hour long. And she had soaked through on 3 occasions. And after the third time of embarrassing what she felt herself by soaking through her clothes, she quit dancing. So she had given up something that she loved because of the impact of bleeding. And when we tested her, she had type 1 von Willebrand disease and was not only iron deficient, but also anemic. And as I was asking her the questions, this often happens, that the mum is there nodding to all the responses as well. So I took the mum aside and did a consultation with her. And she had heavy menstrual bleeding. She had never really gone to the GP about it, or when she had, she was told this was normal. She'd had bruising all her life, but had 3 children and had 2 postpartum hemorrhages. One was described to her as mild, whatever that means when it comes to bleeding and excessively after childbirth. And one was actually quite significant and she needed a transfusion. And she had been going to the GP recently, but more about perimenopausal bleeding, which is often when we'll see women encountering problems. And when we tested her, she had low von Willebrand factor. She was also iron deficient and anemic, but she had had GI endoscopies twice and had an ultrasound pelvis once, but no one had thought about, could this be a bleeding disorder? So this is a very typical pattern that people have to jump through so many hoops before anyone even considers, could this merit a hemostatic referral? So we wrote this article recently about the challenges facing women and girls with bleeding disorders. And they're really myriad. They face it in terms of diagnostic inequalities, but also suboptimal treatments. And to focus, first of all, on the diagnostic inequalities that face women and girls with bleeding disorders, they're both self-imposed as well as system-imposed. Because for women themselves, they may not recognize what heavy menstruation is. We don't openly discuss heavy menstrual bleeding. People don't understand when their periods are heavy. And there's also a normalization, and this is heard time and time again within families, where a woman doesn't appreciate her periods are heavy because they're similar to her sister and her mother, who may also experience heavy menstrual bleeding. Significant stigma exists regarding menstruation internationally, and it's easy to dismiss this as, oh, this is in some other country or some other place, or we're open about periods, we provide care and support to women. But even in this conference centre today, there isn't one female toilet that has menstrual products available or for sale. It's as if periods don't exist. And there's poor awareness when people do go to general practitioners or primary care. There's poor awareness about what constitutes abnormal bleeding. They may not recognise heavy nosebleeds as being particularly heavy or problematic. And when somebody attends, an ear, nose and throat consultant and has cauterization, everyone is looking at the individual bleeding symptom that relates to their speciality, be it gynecological bleeding, nasal bleeding, or bleeding complaints to the GP. And they're not looking at the overall global phenotype of that individual and putting it together saying this could be suggestive of a bleeding disorder. Cumulatively, this leads to delays in referral and diagnosis, and there's good data to support that this particularly affects women. In the Dutch study, they looked at all patients diagnosed with a bleeding disorder and found that there was a 5-year additional delay in referral and diagnosis in women versus men. And this was not just related to gynecological bleeding, because even in childhood, before the onset of menarche, girls experienced longer times and longer persistent bleeding before consideration of referral. And that's probably related to the fact that people are aware of haemophilia and have bleeding disorders and men very tightly associated in their learning and don't appreciate there are other bleeding disorders and that women are more predominantly affected because of gynecological bleeding. Even if you are referred or if you do have tests performed, there's inequalities in specialist testing because there's von Willebrand factor antigens and activities are expensive tests to deliver, they're specialized, they require expert interpretation, and that's not universally available even within higher income settings and is has a very low availability in lower and lower middle income countries. So what are the impacts of these for von Willebrand disease diagnosis and registration? Is there actually an influence on these factors? And I would argue there is, because we have data from the World Federation Annual Global Survey, and we looked at the registered individuals with von Willebrand disease worldwide. Now, to remind you, the expected prevalence of haemophilia is 1 in 10,000. And based on studies by Rodrigo et al. And Bowman et al., the expected prevalence of reduced von Willebrand factor levels and bleeding should be 1 in 1,000. When we looked at the annual global survey data and looked at the number of patients registered per population for each individual country, we had to reduce the denominator from 1,000 to 1 million to actually get a sensible number that could be displayed for some countries. So we should expect to see 1,000 patients with von Willebrand disease per million population. What we found was that median VWD registrations in high income settings was 45. There was a significant range between 1 and 332, which I'm proud to say is Ireland. And then that range between 45 per million in high-income countries, right down to 0.5 per million in low-income countries. So even the most severe phenotypes aren't being diagnosed in low-income settings. And what was interesting was the gender distribution and how this changed and varied based on income status. In high-income countries, you see 2/3 of the population are female that are registered with von Willebrand disease. Now, it's an autosomal disorder, so you would expect an equal male and female prevalence. But because of gynecological bleeding and that burden, women are disproportionately represented in VWD registration numbers. But in low-income settings, you can see this completely changes to where males exceed females. So income status is influencing not only the number of registrations, but the ability of a woman to get a diagnosis and registered with von Willebrand disease. So what about if you get through these myriad of challenges, you finally make it to the haemophilia treatment centre? What does that mean in terms of, are you getting the best care? Is the care being delivered to you the same as for men with your condition? And I would say no, we're actually failing women even in our own centres. And I work in a HTC, so I'm criticising myself as well. Because our centres, even the name haemophilia is very gendered, it's very male specific to a lot of people. And our centres have grown up around the needs of men with severe haemophilia. And we have transposed the outcomes that we use for men, like annual bleed rates, joint bleeding rates, onto von Willebrand disease, where they're suboptimal and they don't consider the degree of bleeding that people can have. If you have 12 periods a year and you use an annual bleed rate, you will have a bleed rate of 12. That doesn't tell you if they're 20 days long or 2 days long. It doesn't tell you anything about the severity of it. So we can't use these outcome measures that we have traditionally built up around men and apply them to women and expect to get good results. We lack female care pathways. If somebody comes in with a hemarthrosis, we would never dream of ringing the orthopedic team and asking them what to do. We manage hemarthrosis ourselves. If somebody comes in with acute heavy menstrual bleeding, is that the same? Or are you ringing your gynecology colleagues saying, how do I manage this strange hormonal bleeding? I don't know what to do. We don't see it as actually part of our care to deliver management of gynecological bleeding. And that's adding to the problems that women face. We have knowledge gaps on optimal treatments because women do not tend to be represented in clinical trials of bleeding disorder products. And despite knowing that the significant differences between the pharmacokinetics and pharmacodynamics for drugs, we take results in a male population and apply that in a female population. And I think we have a real lack of culture of prophylaxis, not only for women, but for von Willebrand disease in general. From the World Bleeding Disorder Registry, they took data from around the world this year, and for the first time, von Willebrand disease was included in the World Fed's registry. And when they looked at the data internationally from low, middle income and high income countries, 28% of adults with haemophilia were on prophylaxis, and 2% of people with von Willebrand disease were on prophylaxis. So everybody with von Willebrand disease is disadvantaged, but I think in particular women are, because when we think about prophylaxis, we think about that haemophilia model of long-term, regular, continuous prophylaxis. Whereas women might only need a short-term prophylaxis as a bridge to a more definitive treatment, like an IUD insertion for heavy menstrual bleeding, or whilst they're trying to get pregnant and have to come off hormonal contraception. And there's no way to guide dosing. There's no dosing regimens for periodic prophylaxis for heavy menstrual bleeding because we don't even consider it as an indication. So cumulatively, you can see the challenges that are imposed by society itself, by our healthcare systems, but also by our hemostasis community on women and girls accessing the care that they need for von Willebrand disease. Now, it can't all be bad news. There are good things happening. And I think it's fantastic, even when to have this session at EHA, to be talking about women with bleeding disorders. And congresses all have tracks for women and girls with bleeding disorders, which is fantastic now. And there's been a number of changes that will hopefully help women and girls internationally. Not only did we have the EHA2024 guidelines, and that brought for the first time a consensus definition of postpartum hemorrhage and heavy menstrual bleeding. Can you believe it? The haematology literature, we didn't have a consensus amongst us as to what heavy menstrual bleeding was or postpartum hemorrhage was before that point. But also in 2021, there was the first European principles of care for women and girls with bleeding disorders. So these were the first principles to outline how we should actually look after women and girls who attend our centres. And it wasn't just for Europe. These are the first ones internationally. So the first time in the world we said, these are the standards we set for our women. This isn't hemostasis specific, but I think it's adjacent to the issues that women face. And the World Health Organization last year released Acceleration Anemia Reduction Report. And this looked at actually highlighting the importance and the prevalence of anemia amongst women. And they focused on a number of areas, including iron, malaria treatment, folic acid supplementation, prevention of postpartum hemorrhage. But a very useful point in this report to really bring it home to governments that don't think it's worth investing in women's health is that for every $1 invested in interventions aimed at reducing anemia in women, there was $12 in economic returns could be realised. And this is how we leverage care and improvements. So we need to actually identify anemia, identify iron deficiency and treat it. And allied with this, I was very happy to work with the International Federation of Obstetrics and Gynecology, or FIGO. And last year they released their first position statement on iron deficiency and anemia in women and girls. And they are relating, as simple as that concept should be, iron deficiency and heavy menstrual bleeding. Surely all of us should think about that. But actually, if you look at the WHO, iron deficiency sits within nutrition, not health. It's not considered a medical problem, it's considered a dietary issue. Now, I have yet to come across a woman with a bleeding disorder who could eat her way out of iron deficiency. Because if you're bleeding, you will lose some, if you have heavy bleeding, you cannot maintain your dietary intake, you will have invariably iron deficiency. And it's only the rate at which that develops that can vary. So the FIGO statement has said that iron deficiency is highly prevalent and the symptom of heavy menstrual bleeding is the most common cause. And it puts the onus on obstetricians and gynecologists internationally to test for, to check and to treat iron deficiency, as well as identification and treatment of the underlying cause. This is a really big step forward, as simple as it sounds. And finally, within von Willebrand disease, we now have the core VWD dataset. So the problem with von Willebrand disease studies is not only is there very few of them, but that everybody uses completely different outcome measures. So it's very difficult to compare products between trials. And the core VWD project seeks to harmonise outcomes for all studies involving patients with von Willebrand disease. And female health was felt to be such an important area within this that they have their own subset of core outcomes. There's a broader core outcome set, but here I have the women, girls, and persons with the potential to menstruate outcome sets that are recommended if women are included in studies. So hopefully this will actually give us some more granular detail on the impact of heavy menstrual bleeding of new products. So in conclusion today, I think it's a time of exciting change. There's momentum behind women's health. And I would advocate for you all to go back to your centres and to look what you're doing critically and appraise how we can improve our detection, our awareness within our local communities, and our treatment for our women who attend us. We can't just keep doing things. My least favourite thing in medicine is, why do you do it? Because we always did. It's time to change things up. So we need to recognise, we need to treat, and we need to investigate heavy menstrual bleeding. Clearly, women with bleeding disorders have more than heavy menstrual bleeding, but this is a cardinal sign of a bleeding disorder. We can use this to identify women and not only reach that woman, but her wider family who may also be affected with a bleeding disorder. We need to improve awareness of von Willebrand disease internationally. People don't know what it is, they don't know they should care about it, and the most frequent response I get from GPs is, I don't have anyone with that condition. And I think, you probably do. You just don't realise it yet. So we need people to care about von Willebrand disease more. And we should be informing that this is a mucocutaneous bleeding disorder, because that's telling you what's wrong and what symptoms people face. We need to develop cheaper, easier hemostatic testing. It's very complex and expensive to deliver VWD testing, and that's imposing a barrier on people who may have this condition in order to access the care. And finally, for the women and girls who are diagnosed, we need to develop evidence-based care to address their specific needs, not what we feel they need, but what they actually desire for us to treat to improve their outcomes, so they can be like that girl at the start, continuing in their dance career, continuing with their daily activities, participating in work and school to the fullest, and not being left behind. And with that, I'd like to thank you all for attending and showing enthusiasm for women and girls.
Just because the community at EHA might not know, but could you give a bit more information on if there are new treatments coming for von Willebrand? Because I think traditionally people know about the IV formulations, but do you have any insights in what is out there?
Well, in terms of von Willebrand disease, I still think we're so far behind haemophilia. And you have, traditionally we've relied on plasma-derived von Willebrand factor concentrates, and in the setting of things like the Infected Blood Inquiry in the UK, that's obviously very challenging to recommend prophylaxis with plasma-derived products of any variety, even when they're doubly virally inactivated and considered safe. We have obviously a new recombinant von Willebrand factor that's recently been licensed for prophylaxis in Europe. It's been more widely available in the US for longer. These are very expensive products. And then there's pipeline products that are coming through, like BT200, that are still undergoing clinical trials. There's also VGA036 is on the line, but things are slower to progress than they are for haemophilia. What I'm worried about is that expensive products coming out doesn't improve access to care. And we need to be looking and taking a step back at what we already have in our armamentarium and offering that to people. So DDAVP is a fantastic treatment, desmopressin. That's broadly available. It's on the WHO essential medicines list, so it should be in every country. Tranexamic acid, that's also an essential part of most women I have and most patients I have with von Willebrand disease will have tranexamic acid at home. That's cheap unless you live in America, but that's a cheap and cost-effective option. Unfortunately, that's only in an IV formulation on the WHO Essentials Medicines list based on the woman study for postpartum hemorrhage. Oral tranexamic acid isn't an essential medicine. So that's something that we're campaigning for as a community to make, if you're in a country and you can't get access to maybe plasma-derived VWF concentrate or recombinant, the fact that you can't get even oral tranexamic acid is a massive barrier. So I think what we need to do is, and I worry in haemophilia treatment, that we have such fantastic treatments, but we're increasing the disparities globally. I want everyone to come along together and bring people up together rather than, I hope that drug companies won't just focus on very expensive treatments that will be available to few, but improve treatment for all.
My question is on how do you think we can improve the access to diagnosis and also one thing that I've seen in the testing of the von Willebrand disease is high false negativities? How can that be improved?
Yeah. So two questions there. The first one about false negatives. So there's so many factors that affect VWF levels. Most 16-year-olds that come to my clinic for the first time will have high levels of phlebotomy-related stress. So I will tell them, I don't mind if your levels are normal now. I know they're probably much lower. We'll see how you are after a couple of visits and you realize we're not terrifying. But certainly stress will temporarily put up VWF levels. What we have looked at in our centre is we reviewed about 2,500 VWF levels over a 2-year period. And we found that if your initial level was above 70, we had only one case where the plasma VWF level on repeat at any point was less than 50. So once you're over 70 or 80, I think your levels are probably above 50 at baseline, even if you have things like phlebotomy-related stress. So that would be about, having thresholds or understanding how von Willebrand factor can be affected. People often worry about doing VWF testing on the pill. That's something I hear a lot. You would need to be on a greater than 50 microgram or 50 microgram ethanol estrol pill, and most pills are 30 or 25. So that isn't as much of an issue now because there's lower estrogen formulations. The first part of your question was about how do you improve testing worldwide, and that's a much trickier issue. The World Fed, to be fair, are trying to work on point-of-care testing for blood drop von Willebrand factor antigens. So at least you could get an antigen in a low resource setting, on a card-based test. It's very challenging to deliver that. There's also, I think, potential for paired schemes that you could have centres internationally that samples could be negotiated and funded to send to those centres to test and relay the results back. We live in a much more interconnected world, and there's opportunities to actually provide real-time results through, emailing information forward and back if we set up those networks properly. Because I think investing in labs in every country that can deliver VWD is probably unrealistic, but investing in partnerships to help and support will help people get diagnosis and build up capacity.